But yeah, Lisa is
Not
only
for long.
partially here. She's in the United Club. We don't know what's going to happen. We never know. Okay. All right. Welcome to the Health Tech Talk Show. This is like a special episode of the Health Tech Talk Show, y'all, because Lisa's in the United Club. We're going to lose her here. We might lose her entirely because she's on United. So we don't know what's going to happen. But she's enjoying herself. She had a long week in DC. So we have Leslie Kirk, real CEO of Incentacoma LLC, who is partially subbing as co-host for her this week.
Partially.
And then we have, of course, who everyone's actually here for, Melissa Denino, totally living it up here. We have like two amazing guests. We have like a lot of news to cover. We actually don't have a lot of news to cover. We only have a few topics to cover, but it's gonna take a while. And then we have
I think the Health Tech Talk Show broke the internet this week, like for sure.
No, it definitely think so. Oh my god,
we broke the internet this week.
Is that why we didn't get any tips? Like, is that why we didn't get any? Like, I mean, no one gave us.
That's why, guys. That's why. That's the reason.
Oh my god. Well, yeah, that was why it like broke our. Whoa.
She's gone.
Maybe she'll come back. Maybe she won't. But we have Dan Mistak of COCHS. We're going to be talking about like correctional health. He also wants to talk about some other things we're going to talk about. We don't know where Leslie is. I think she'll come back. I'm not sure. And then we have Shannon Sartin West. Also Shannon West. I don't actually know. She'll tell us later how she prefers to call herself of Datavant. So it's going to be like amazing. Maybe Leslie will be back. I'm not sure. But so Lisa, while you're still with us, why don't you just start out by telling us like what happened? What's the big news?
Oh my God. Listen, I've aged 1,000 years in the last 4+ days. Yeah, I mean, it's now, I think if anyone hasn't read, which probably many of you have not read, but our friend of the show, Brendan Keeler, wrote just an exceptional post, which I strongly recommend interested parties read. He's made it public on his Substack, Health API guy, just really talking, hey, there's Leslie. Oh, no, she's gone again. Whatever. Everyone else is not on video. I have no idea. We're getting all kinds of messages. Okay, well, that's fine. Basically, there are national networks. There is an incredible, like really fantastic explainer if you're new to the national networks. The big ones are eHealth Exchange, which was the first national network. It's the successor to a bunch of other stuff. Then there's Commonwealth, also been around for some time. Then there's a national framework for data sharing called Care Quality. And various parties can pull data based on principles of being clear about what they're doing it for under HIPAA, the treatment, the purpose of use, and also on the principle of reciprocity, meaning if you're sharing data for treatment and you ask for something, you got to also send something back. And that's kind of all there is to it. And long story short, looks like there were some parties who were not following those rules. And it's a complicated story why it happened. And I encourage you read the actual like primary sources, don't listen to us try and explain it to you about why this happened, but Epic took some action based on evidence they had, and they shut off one of those parties, Particle Health. And there was a whole hoopla over the internet over the weekend or whatever weekend, I don't know. Some days time isn't real. It's been going on for a while, and more information has come out about it. And that's what you can see in Brendan's great post, kind of the timeline of events and all the people and the things. And in particular, now I'm speaking for Kat, as our loyal watchers know, we are both XXX PR gals. And we were pretty surprised about the communications failures in this entire thing. Like our personal interest is like, wow, that was a bad choice. And I think that's what Kat wants to talk about. But that's kind of the background. Like read Brendan's post. It's freaking great. Brendan did a great job.
If you want to fight about like purposes of use and like, should the national networks like come up with different pathways for other, payment and operations, like I totally agree. What we're going to talk about today are like really fucking shitty communications decisions. And we are going to specifically be talking about Particle's decision to blast shitty lies all over the internet and to destroy trust like pretty much across the board. Like that's what we're going to talk about. So so to start out, like this is a publicly available document that you can find on Particle's LinkedIn page where it appears recently retroactively terminated to January. Troy Bannister, founder and former chief strategy officer of Particle, also posted this a version of this on his own LinkedIn page, and we're just going to talk about like how much this damages trust across the board, and tried to deceive the market, and how it's like total bullshit. Also, I just want to point out when I downloaded this from Particle's LinkedIn page, the title is drafting. Like maybe they didn't finalize it, or maybe this was a rush decision. I don't know. Anyway, so that's that. So like there's two tactics that that I believe, and Leslie, interested in your opinion as another PR professional, used when writing this communication. And to be clear, like I still have no freaking idea why anyone in their right mind would have posted this post on the internet. Like I cannot figure it out, y'all. Like because like Lisa, as you know, and maybe some of our other guests will be allowed to confirm for us, a lot of these disputes just like get taken care of privately. And you'll notice neither Epic nor Care Quality have issued a public statement. This was Particle's choice, and like probably I don't know whose idea this was. It was not a good idea. So what they did was they, in my opinion, tried to leverage public disdain for Epic, right? Because Epic's big, Epic's scary, blah, blah, blah. So we like just spread that over the news to try to deceive the public, which honestly like worked for a lot of people. Like a lot of people were like, yeah, Epic's mean and you're just the little guys and like David and Goliath and rah, rah, rah. Right? So like we're going to talk about that. We're also going to talk about the fact that this communications approach also relied on the real reality that like a lot of people are scared to come forth because we are all under 400,000 NDAs. And like you can believe me or not, I got like dozens of messages from people saying like, oh yeah, like thanks for saying that. Like I can't come forth because I got to pay my mortgage. And that's like a real thing. So like this all like, I don't like, I would love to believe that this was like a well thought through strategy. It probably wasn't. From what we've heard, conversations with Epic and Particle were going well. And then Particle like out of the blue, like threw this on the internet. So, and you'll see in the communication that Epic provided, what is it called, Lisa? It's like what's it called? It was the risk, third party risk assessment that Epic posted to their customers. That's now on. Yeah, this is available on
third party privacy risk notification.
Yeah, you'll see they've been in active conversations up until it sounds like when it was posted last night. So yeah, I don't know why Particle decided to like blow up the internet and kick things over and lie, but they did, and that's unfortunate because like they didn't have to do it that way. That's like a total wild thing. So oh wait, there's stuff in our comments. Anyway, okay, yeah, so that's that. Also, the other reason this totally pisses me off, y'all, is because this was like, again, this could have just been handled. And y'all, there are people out there who have been like brick by brick, inch by inch, their entire careers building these national networks and trying to make health data exchange actually work in our country. And it was like, I mean, still is, right? Hopefully, kind of working. Like we're getting there. Like all these things are happening. Like TEFCA, like should be happening. Like all these things are happening. And then this guy like gets in trouble and is in a dispute and decides to blow up the internet and lie. And instead of just being like, hey, I'm going to deal with this, he's like, you know what? I'm going to kick over the other kids' Legos. Right. So like just like causes distrust across the whole market. Everyone's dealing with like, are the national networks even real? Right? It's just like total freaking bullshit. And I'm mad about it. So before we go line by line into all the lies in this letter, Leslie, guest host, communications professional, do you have any opinions?
Oh, I have so many.
Who did not kill me? Who did not manage to kill me off? She said she was going to kill me off. I'm still here.
Yeah, listen,
still time.
Still, I really meant to try harder. So honestly, it's giving me Elon Musk vibes. Like originally, before I saw that it was like an official website, official company like position, I thought it was like just a rogue founder who has, who kind of lost track of who he was. So I'm excited for us to go through the letter, because it kind of just felt like that. It just had very Elon Musk vibes, where you get slapped by the board and like nobody really cares and takes it seriously. But like this has caused like a real ruckus. So Anyway, let's go to the
Yeah,
letter.
fired by the board energy, as Lisa would say. I feel like, yeah, I don't know. So anyway, okay, let's start out. First line. Okay, so these are all like zeroed in screenshots, or not zeroed in, zoomed in screenshots of the particle letter, which is on the internet. So it starts out, lie number 1. As reported, Epic recently ceased responding to certain medical record requests submitted through the Care Quality Network. So this you could say, if you slam 12 beers and squint, you could say, oh, it's not a lie. Like that actually happened. Except that we have left out the key part of this statement, which is that it was only for Particle and their customers. It was not everybody. So like, okay, like let's talk about massively deceiving the market, which like is a load of bullshit. Next, Leslie, tell me about using math with no purpose. Why would anyone do that?
You know what? I don't know. Listen, to manipulate an audience. That's why they would do that. So
Yeah.
you're talking about the 6 million, right? Yeah.
Thousands of patients, 6 million encounters. Lisa, as president of the HIEs, as you are sometimes called, even though I know you're not, like how many encounters are we hitting? Like a day, a year? A lot more than 6 million.
I'm here on my own behalf. I speak for no one but me, and barely even for me.
I love legal clauses
because I've had a long week, and this is not water. So I mean, as we know, math is not real, and math is directional. Numbers, data are at best directional, and it's a big number, so it makes you feel like this is a real big issue. Those meanies, big meanies. That's what I get from this.
6 million patient encounters. Not a lot, y'all. Insignificant in the realm of data exchange. So, and then the other thing here, this is all paragraph 1, y'all. We haven't even made it to 3, 4, or 2, 3, 4, 5. Unilateral action, y'all. Okay, so again, go over to I have it up here. Epic's little sequence of events that their third-party risk assessment thing that they sent to their customers, which somehow is now on Health Tech Nerds. Weird. This was not unilateral. That is deceiving. It was also the decision recommended by the Care Everywhere Hospital Council. 15 hospital representatives recommended this. And you can see it was a long, long effort to get to this point, 6 or 7 months, because I can't do math. It started in, I think they said October 2023. I can look that up somewhere. Yep, October 2023 to April 2024. So, y'all, come on. All right. Paragraph 2, despite efforts to resolve the issue quickly. If you wanted to resolve the issue quickly, you probably would have kept this shit quiet. And then this is like my favorite part. I'm really excited about the graphic on the next slide. That is because Epic's privacy thing names some of the companies they were concerned about, pulling data allegedly under treatment purposes. So I love how they're talking about like rare disease specialists being hurt here, rural health providers. Like these are things that like I really care about. As everybody knows, like I'm totally down with some underserved communities. Leslie and I just gave a shit ton of money to Cancer Acts because we care about the underserved. However, I would just like you to see the company that they're representing. This does not appear to be a rare disease specialist nor a rural health provider. So like weird. But yeah, like back to this. The other thing here is if rare disease specialists, rural health providers, actual clinicians are like have valid treatment use purposes, like they can get this data. Like this is not impossible. So, deception. Back again, I just want y'all to, this is one of the customers named in the Epic notice. It's real. This is from their social media channels. All right, moving on. Paragraph 3, to our knowledge, all affected partners directly support patient services. I'm just going to move on from that. All right. The sudden disconnection. The sudden disconnection, again, clearly stated here. And this was also in Michael Marchant's comments on Troy's posts, which have since been turned off. So thankfully, someone screenshotted them. So we can still see he provided very sound rationale and basically said, like, you're lying. I mean, he didn't say that, but I did. And it says, starting in October 2023. Over the course of several months between October 2023 and April 2024, Particle Health, Epic, and Care Quality had multiple conversations related to processing new entries and Particle Health's implementer obligations. This does not seem sudden. Like, how many months do we need to be called sudden? I am confused. Anyway, it is nice that they said that they're very delighted that Care Quality and Sequoia are being collaborative. Congratulations. Leslie, what do you think sudden means? What does sudden mean to you?
You know what? I don't really care, but I will say that they doubled down on it too, because we're talking about the comms part of this. So whoever wrote, like, they doubled down on that, the unilateral, and then now the sudden disconnection. And it's like, it's such a really, I mean, not to cut ahead, but it's such a risk. Like, this is a provable lie. Like, this one in particular, the one they doubled down on, was a provable, clearly, like, not just like some guy standing up and saying like this didn't happen, but like, there's paperwork, there's a paper trail. Even with NDAs, there's too many hands in the spot, and like, you just don't keep. I don't know. That was just such an interesting thing to double down on when I was reading it. Is the actual provable part of it, So
that's what's wild here. And again, it's not like we're just like slamming a bunch of beers and like saying like, that's not what we meant. Like, this is like real. Like, these, like, that's what I'm saying here, y'all. Like,
I mean,
this is Kat McDavitt's opinion on lying. This is like lying. Yeah. So anyway, that's that. I think we're almost to the end. Thank God, because like, I'm like so tired of this. Okay, I think, last paragraph. Love it. Totally great. Stay tuned for additional information. We are striving to expedite to a resolution. I mean, again, I don't think the fastest path was to blow shit up and lie, because we're still here talking about it on the Health Tech Talk Show. But you know what? It does sound like an Epic's privacy notice. They say that they are even after this was posted, they still say that they are trying to find a resolution. So that's pretty nice. So again, like, I know people.
I have a question. What do you think the word value means in terms of data? Is it like quality value, or is it like money value? Just a poll. Just doing a poll here. Just
like in general, or like in this.
To quote some of our internet friends, just asking questions. What do you think value means in terms of data?
Well,
if you say you're going to try to get more value out of the data that you collect, what does it mean?
More value out of the data you collect.
Well, I think that lawyers are probably trying to make more money. So I don't know. Is that what we're talking about?
Yeah,
could be. Just saying
like,
things.
If you're a clinician, like, you probably think like, richer
new revenue streams,
more information. But I think if you're like a vendor, like, we're probably talking about money. I don't know. What do you think, Lisa? What do you think?
I just get worried, right? I don't want to be like the word police, right? I mean, we're being a little bit of the word police here. Somebody wrote this, they were not very smart about it, and I'm sorry for them, because it really blew up in their faces. And also, at the same time, like, we have to be a little bit careful, because any discussion of commercialization of patient data is like fraught, and there's reasons why it's fraught, like good reasons why it's fraught. There's all kinds of equity issues. It's very complex. There's not like one of the things we hear about a lot is like, patients should own their data. Well, as we know, patients don't own their data. Data are owned by the company or the organization, usually the hospital that like has a license for the EHR, where their data sits at that moment in time, right? To get really annoying and like, technical about it. And then, there's all these like new rules about data sharing, like 21st century cures and the information blocking rule, Kat's favorite rule.
I love it.
Like, great. That's really wonderful. Except for they're all built on this, what I think is a little bit turning out to be a bit fake. The idea that the basis is that patients should be able to access and request their data through individual access services. Cool, but that's not happening because the structures aren't there, and IAS is basically the equivalent of optional in the national networks right now, unfortunately, which is not cool.
Yeah.
Right? Patients should be able to access their data, but you know what you have to do to prove that? You can't just say, some patient told me it was okay to use their data for something. No, you have to be able to show the actual patient is like a real person who was there, who like identified, who authenticated through a method that we all agree on, like in a very specific way, and said like, I I approve this specifically. It's me, facial recognition. It's me.
Yeah.
It's a very different story than me. Like, patient told me, like, at some point in time that I could access these data. So my point is just, I'm complaining now, of course, but like, come on.
Yeah.
You have to be careful with this. It's important. Trust once lost is hard to regain.
Oh, 100%. Yeah. One thing that was really interesting and compelling at the end of Brendan's post, for anyone that hasn't read it, is like the end, he puts like his ideas as a product, like all the things at the end of ways to do it. And one of the ones that struck me was the one where a patient could go in and actually just pull all of the inquiries it had on their data. Now, then there's the point of like, well, if they don't like one, really, what's their path to changing that? But, still even be able to have access to it. The fact that people don't even know where their data is getting exchanged is, kind of mind blowing. We probably don't want another tangent.
I think the average patient would have like no freaking idea. How much their data gets flung around, like truly. And I'll say one more thing about like we were talking earlier. We believe, we can't confirm because we didn't take screenshots of this profile when we were looking at it earlier in the week, but it looks like Troy's profile has now been changed, that he is not a representative of Particle Health. It looks like we can't confirm, but it looks like it was revised to say that he, as of January 2024, was no longer a part of Particle and has been a venture partner ever since. So anyway, that's some solid scapegoating if that's what they're trying to do here. Whatever. Like Lisa says, we change our LinkedIn profiles all the time. The timing's just a little suspicious. So that's that. But we do also want to call out, God bless Michael Marchant. He was kind of a hero. He spoke up and went against the drama that was created by that letter. And unfortunately, his comments were turned off. But there are screenshots everywhere of what he was saying and kind of rebutting the claims that Particle was making about not being informed that this was happening. So this guy's great. Good for him. It's hard to go first. It's hard
it's hard to go first, and it takes a lot of he obviously has an important role of a lot of responsibility, being in charge of this Care Everywhere, which is the internal Epic group that does the internal Epic sharing and the connection to care quality. It's really hard to do that. I also just like it bums me out to sort of I don't want anyone to think for 1 minute, again, my total personal opinions here. Like, there are all kinds of issues with Epic as an organization, massive organization. There's all kinds of issues with huge organizations in healthcare with lots of data, like general statement, right? We all just are, I want to say we got through the Change Healthcare thing, but it's like literally still going on, and like providers still are getting paid. There's all kinds of disruption that still exists. And there are a lot of risks to having all these things in one place. And there are a lot of risks to large organizations, large companies without any meaningful competition in this space. So I would hate if anybody thought that I had any particular personal stance on that beyond just saying, like, I think people should be honest with what they're doing. They should be above board. They should work really hard to regain and maintain trust in exchange, because it is so hard to regain once lost. So like, shout out to Michael, because he is like out there doing the work. And also like, it's a complicated story. Like the whole thing is complicated.
Right.
Yeah.
I was wondering about like, because I wondered two things. I was wondering if they thought it was worth it. Probably not if they're doing the scapegoating thing and changing, his title. But
alleged.
The other thing was like, alleged title. The other thing would be, I don't, because
allegedly
in the comms world, like Epic is notorious for not engaging in this type of conversation, right? Like they own 38 or 40% of the market. Like they don't usually respond to these things. So I was thinking about that too. I wonder if he posted it and they posted it because they had to tell, for whatever reasons, right? Like internally, they're trying to do something, or they're trying to point their customers to something they're doing right because they're doing other things wrong, or their financial straits, whatever it is. They didn't think that this would actually blow up because Epic never responds. So oops.
Well, they didn't. They did. That's the thing. So you all, as like Leslie, as like an actual PR professional, one of the great strategies is to use proxies, to use trusted proxies to speak for you. And I think in this case, I mean, again, Michael's role. Now we're speaking for Michael. Michael's role is like an actual designated one in a governance. Like he's a part of a governance model that exists. It's like a governance council or committee of their customers, just like Care Quality has a steering committee, Health Exchange has a steering committee, all these other TEFCA in theory has the QHIN, although it hasn't really started yet as far as I understand, like the QHIN governance council of the different QHINs, like, this is a standard process. All the organizations that I, am associated with, but not speaking for, also have their own sort of governance models, corporate governance. I'm actually live right now, so maybe not right now. See, this is the problem with being United Club, is getting someone coming to take your plate, which is very kind, but not right now.
Maybe they'll get you another drink, Lisa. That's on time.
Maybe they will actually. Yeah. So the point is like using proxies, using trusted proxies is like a strategy, right? Like using someone speaking for you positively is a good PR strategy. Is my point.
Yeah. So I'll say, we probably should move on because we have like real guests who have real things to say. Again, this fun section of the Health Tech Talk Show was about a really poor example of communications, right? Like super bad, like lies, right? Like we said, like you can clearly see that this was not true. And in addition to Epic's thing, like you can say, Epic might be lying, but like a lot of people have said, no, this has been going on for a long time. So, you can decide who you want to believe. But the other thing here, what I think is important is like, this did damage trust, not only with Particle, but with the national networks in general. But I think like it's also an opportunity to say, hey, like, what can we do to make sure this doesn't happen again, right? Which is an opportunity, like, thank God. So you'll see in the Epic notice, Epic again requested, this is their last statement on like things that are happening. Epic again requested that Care Quality move quickly to convene a dispute panel, which as of today has not been established. And this was dated April 10th, 2024. So like making those changes is meaningful, right? Across the board, like how do you handle disputes? Like how do you handle this kind of thing? And that's meaningful. And even for TEFCA, like how can you, in this early phase of TEFCA, make some changes so that it, we don't have these problems. Because this is important, and it's important that people's health information is protected. And it is a freaking shame that some guy like put something on the internet that's a total pile of shit, and like everybody's thinking that these national networks don't work or whatever it might be. They do work, and it depends on trust. And unfortunately, we have to like get that back. Okay, like onto some other news. Auto site best party of health and vibe 2023 and 2024 announced a big thing on the internet with Mark Cuban's company. What? God bless Otto. Congratulations to the Photon team. This actually, I was so busy being mad all week that I actually didn't read this press release, but like, who did? No one. God bless you, Otto. We only read the headlines. So
I think he would not be offended by that. I just think, I think he mentioned this to us briefly when he was on the most recent time, I want to say. And all I'll say to this is, Mark Cuban, come on our show. Otto, please bring Mark Cuban on our show. Thank you.
Leslie, were you going to say something smarter?
I read the press release. I mostly just said that they're partnering. So I don't know that there's like a lot of details out there. So I didn't get the impression that there was a lot of details out there.
Oh, I'm so happy to hear that. Okay. All right. Fantastic. Yeah. Okay. The other thing here, this is, again, our news show is pretty late on the news, pretty long on the analysis of bad communications. But Lisa, I think you shared this, and it's about like not understand, like it's less important that you understand statistical analysis. It's more important that you understand where it came from and why. Leslie, I know you have strong feelings about this. Everybody, like Leslie, her passion project is medical mistrust and like not having that. So what are your thoughts on this, Leslie?
I mean, I don't know. Was this based on a study, Lisa? I like found out about it like 20 minutes ago. So because obviously PR
no,
is the best math, which is essentially statistical analysis. Go ahead.
No, Dr. Murray here is just one of those great epidemiologists, public health people on Twitter, which is sadly going away. That used to be a great place to connect with really interesting science thinkers, and I just really like her perspective. And I think this is just so important, right? I had a question yesterday from a member of Congress who was like, "So AI, tell me about it. What do you think all these data providers can do about it?" And I said, just so much inherent bias, like structural, systematic bias, and like whose data is available in these systems. And it matters. It matters for training AI, right? Like, don't do it without huge caveats. Be incredibly careful because the bias is like built into the system. It's just, you have to understand, where did it come from? How did it get there? What does it mean? Who cleaned it and how do they do it and why? Like, these questions are really important, and they apparently don't occur to a lot of people when they're thinking about how to use the data we have.
Yeah. Well, I also think it's because of how convoluted most, depending on who we're talking about and like which kind of companies or which kind of organizations or government or whatever, different people are asking different pieces of these, right? Like some people are asking, when did it happen? Some people are asking, where did it happen? How did it happen? Who did it come from? And like, they don't always talk to each other. You know what I'm saying? So like, it's just like, it's like a headline culture back to the last one. Yeah. Yeah. So, people digging in, they're ready to take the first thing they see as opposed to digging in. But maybe that's changing. I feel like, I mean, not to take this into, the medical mistrust world, but people are starting to realize that no one's going to advocate for them besides themselves, right? So they're starting to try a little bit harder. They just don't know how to do it. And so, I agree with this statement. I think it's awesome. I also think that you can also like the problem with this is that you can tweak any of these answers, right? That's where I I'm gonna die a paranoid person, is like, you can change the answer to any of this. If you, so like, that's like where, when, how. I mean, statistics aren't just the number and how you phrase it. It's like all the pieces around it and how you manipulate that information. So we might all just be screwed forever. Who even knows?
Well, we probably are. And to quote friend of the show, Paul Wilder, my mom's favorite guest on the Health Tech Talk Show, he tells me, I don't trust anyone. Yeah, my mom loves Paul Wilder. So yeah, Paul Wilder trusts no one. Neither should you. Exactly. All right, we got to get to our real live guests here. So we actually don't know if her video is going to work. Oh wait, Shannon, I did send you another link in case you would like your video to not be going in and out. She's here. Oh, no. She's not here. We don't actually know.
There she is. Am I here or am I not here?
I mean, you're here.
Blinking. You're like blinking.
And we can hear you. Yeah, it's like super weird. Shannon, if you check your Datavant email, I just sent you another link.
Let me go to my other computer that I was trying to figure this out on. So I'll be right back. Go to Dan, and then I'll be just going to come to either one of our houses. That would have been fine too.
Okay, you know what we're going to do? Okay, you go do that, Shannon. We're going to do what we always do. We're going to improv, and we are going to cut over to, real quickly, our friend Dan from COCHS. Yay! So Lisa, wait, hold on. I gotta change something real quick here, because like I didn't know it was gonna happen with this show. Here we go. Okay, so now there's a bunch of us here. Hey Dan, how's it going?
It's going all right. I probably should not have accepted that job at Particle Health, but now I'm learning from my mistakes.
Listen, I don't know. You could make a difference though.
That's what I'm hoping. Yeah. I think with my skills, I can really turn that company around. I hope I don't get drawn into any lawsuits that you all are going to be subject to.
No, I don't know.
For legal purposes, that was a joke. It was not serious.
Absolutely.
Just so everyone knows.
Yes, definitely.
Yeah. Anyway, Melissa, can you introduce Dan to our loyal audience? Because I know you all are doing some cool stuff together, and he is working on something adjacent to your passion project.
So Dan Mistak is a wonderful human being and works with the community-oriented correctional health services, otherwise known as COCHS, and has been amazing in helping and guiding me in my passion project, is driving the 1115 waivers that are in the states right now to get Medicaid to justice-involved population prior to release, and is generally just an amazing person and a do-gooder. So, how is that?
Do-gooder.
Do-gooder, Dan Mistak. So just that's my intro.
Dan Mistak.
Yeah. So go ahead, talk.
Oh,
yeah, Dan,
great
tell us.
talk. All right. Yeah. Well, I appreciate being here. I'm really grateful for this. I had a lot of fun watching. I was really really that there was going to be some pop quiz or something that you ask all guests. I did not see that, so I'm breathing a little easier.
There's no plan.
But yeah. Well, thank you all for having me, Melissa. Thank you for the connection here too. As she said, I work at a nonprofit called COCHS, Community Oriented Correctional Health Services. We actually started in 2005 with a grant from the Robert Wood Johnson Foundation in order to try and bring in really FQHCs inside of the jails, because jails are places where people receive healthcare. In fact, there's like 10.2 million bookings into a jail every single year. Every single one of those bookings, for the most part, has at least a health screening to figure out if someone is okay to detain them. And then from there, many people who are incarcerated because they have some pretty acute unmet mental health or substance use needs, many times. And then often when they are incarcerated, their health gets worse. The challenge is that these jails, as healthcare delivery sites, are completely disconnected from the broader health systems. So what we've tried to do is bring in community providers so that there is some sort of continuity of care inside and outside of the jails. We've done that through health information technology, trying to connect jails in, first help them get electronic health records, because a lot of them are just on paper records, and then be able to use those electronic health records to query a health information exchange to identify whether or not an individual is in the midst of perhaps their first psychotic episode. Maybe they haven't filled their prescriptions for the last 2 months, and that could be really an explanation for why they had an encounter with the police. With the hopes, in my hopes, of diverting those individuals away and putting them in a much more appropriate place. Rather than a jail. And then also making sure that people who, when they are incarcerated and they're leaving, they can get connected to services. So on the outside as well, so that they don't end up being rearrested or taken back in on the other side. So it's also a really exciting moment in this time. As Melissa mentioned, Medicaid is coming inside of jails. So Medicaid actually has been prohibited by statute from being available, Medicaid services inside of jails. So that has really created sort of a shadow health system that exists. And then we just kind of overlay this sort of like moralizing side of, oh, well, these are criminals who are here. So we don't really need to care about their health. And so it's a very, very convenient system for invisibilizing some of the most intractable problems inside of our world. So I'm pretty excited about Medicaid coming in, because it's not just financing inside of the system. It's also bringing in new eyes, transparency, new incentives for people to be able to actually bring in more electronic health records. The most recent appropriation just had a grant program in it, $113 million earmarked for jurisdictions across the country who are interested in trying to improve their connections between jails and community systems. And then just this last week, HRSA announced that they would allow for the first time FQHCs to actually start providing services inside of jail within their scope of services, which is absolutely huge for a lot of things like workflow and also getting around some of the sticky issues of like managed care and things like that. So anyway, I'm thrilled to be here. That was a lot of talking all at once, but happy to chat about any of it.
That's fascinating.
That is so awesome. I'm so glad to hear that they're finally like letting some more services get into jails and prisons. I mean, if it weren't just, ethically such a problematic, troubling, like awful way to think about people, I'm sure you know the statistics of the number of people who are, wrongfully convicted or serving ridiculous, terms, and just the, if it weren't just already awful, like from an ethical perspective too.
Yeah.
I got kicked out.
Yeah. Oh, you're coming back. You're coming back. There we go.
and the thing is that like that's like after people are sentenced. So jails are just holding people. They're warehousing people who haven't been convicted of anything. Often, in many places it could be, for example, that someone's homeless or someone has substance use disorder. Well, we don't have a crisis response. So what do we do? Well, we'll just put them in jail. And also that really increases the burden on local jurisdictions too, because all of the healthcare costs inside of jails ends up being paid for with a local jurisdiction. States, for the most part, pay for prisons. And so we're creating these completely disconnected health systems that really it's a completely unregulated market too, by the way. I mean, there really is no oversight. Basically, the Eighth Amendment of the Constitution is what guarantees healthcare inside of these facilities. And the standard is that that the jurisdiction is not supposed to be deliberately indifferent to the serious medical needs of the person who's there. well, what does that mean? So that's not really a high standard of care on the other side of this. So it's really it's going to be a massive change to both systems, frankly, because Medicaid has has been not touching these people's lives, or maybe touching them on the outside, or they've been the ones that are challenging to reach, and now they've got to try and figure out how to do delivery inside of jails, and then also these jails have to figure out how to bill Medicaid for the first time. They have to figure out how to meet all of the different requirements to participate in the program, and it's going to be a pretty heavy lift.
Are they prioritizing? Like, are they prioritizing certain groups or certain disease states or certain, what are they going to do to start with?
Well, so the way that it's being done, there's a few ways that this is actually being accomplished. One is that there is a statutory change. So the reason why Medicaid's not allowed is because of something that was baked into this Social Security Act amendments in 1965, something called the inmate exclusion. So it's the same sort of it's actually in the same area of the statute that did not allow Medicaid to pay for institutions of mental disease. So this was after the waivers were allowed for IMDs, I started rattling the cage a little bit and saying, well, if we can waive the inmate or the exclusion for IMDs, why are we not doing this around people who are incarcerated too? So inside of the Support Act in 2018, CMS was charged with trying to figure out how to release guidance to allow states to ask for a waiver. And so last year, California was the first state to receive an 1115 waiver to allow for Medicaid services behind the walls of the jail. And then since then, Washington has had their waiver approved. Montana has had their waiver approved. And there are like 22 states or something that are in some process, either with the local or at the state comment period or at the federal comment period, that are rolling it out. So there's the regulatory waiver way of going about this. And then there's a statutory change that goes into effect January 1 of 2025, where states are supposed to have in place a plan to offer screening and diagnosis of the EPSDT benefit, and also 30 days of case management before and after release from a public institution for Medicaid-eligible juveniles. When our colleagues on the Hill were crafting this legislation, I don't know what they were thinking necessarily, but there are a lot of Medicaid-eligible juveniles in adult facilities. So this is not just juvenile justice facilities that are going to be having to figure out how to do this January 1 of 2025, but also adult facilities, prisons, jails too. So it's wild.
I hadn't even thought of that. That's crazy. Thinking about the juveniles in the adult prisons and the fact that they didn't have access to healthcare when they're, might be 16 years old or whatever. That's interesting. Fascinating. Yeah.
So Dan,
and then we frame it in terms.
Oh, well, no, I mean, you can keep going. No, I was going to say, I think everybody, the whole market's like, it's so great that we're doing this. These waivers are amazing. But I think you're outlining some serious challenges. You're saying even the tech challenges, how, they don't even know how to build.
Yeah.
Right. Yeah. I think a lot of jurisdictions are probably the dog that caught the car at this point. I mean, they're like, okay, we've got the chance to do this. A lot of sheriffs are interested in this, right? This is a huge liability for them because this is what they get sued for is bad health care in these places. So they say, well, we'd love to have community provided. We'd love to have Medicaid paying for this and take this huge burden off of our shoulders too. But the fact is, since 1965, we've got the correctional health system has grown off and evolved that way. And then we've got the entire community health system that's evolved that way. And now in a short year or two, we're expecting those two to evolve back together. It is going to be a really interesting challenge, but this is what we're doing. We're trying to bring in populations that have been ignored for a long time.
Forgive me for, this might be an ignorant question, but private and public privatized prisons too? So not just the state-based? Okay.
Right. Well, so I mean, the private prisons are contracted with the state, right? And so, for example, I've worked in Hawaii a lot. I used to live in Hawaii before I moved to sunny Ohio, and in that process,
is that why you smile so much? Got it. Understood.
Yeah, I love it. Yeah, I love Ohio. I mean, I was under the totality went over my house on Monday, so that was worth living in Ohio for the rest of my life for sure. But yeah, so I mean, it's the interesting thing is none of this has changed a single statute or anything that regulates the correction system. This is all by changing Medicaid rules and Medicaid law, those statutes too. So, there's no carve out for any sort of private prisons. Inside of the waiver aspect, though, federal prisons aren't covered, and that's because of the matching aspect of like Medicaid matching. Can't match a federal dollar to a federal dollar, so they just basically were like, we're not going to touch any of that. But yeah, some of these private prisons. Oh, I was talking about Hawaii and then forgot. Just wanted to gloat that I lived in Hawaii but no, the truth is that, a lot of folks who are incarcerated in Hawaii are taken to a facility in Saguaro, Arizona, which is obviously like not fun if you're someone who lived on an island, your ancestors lived on an island your whole life. But the truth is that the facilities in Arizona are like significantly better run than the ones in Hawaii themselves. So, a lot of the like concerns about private prisons, I think, are not exactly the best way of framing the challenges, because we've got really bad systems, and of course the really easy knee-jerk reaction to say, well, it's the privatization that's the problem. And I think really the problem is that we've just decided that people aren't worth our time or aren't worth our consideration, and so we just put them in places where we can't see them anymore.
Yeah.
So Dan, I think two more questions for me. So I think, have you seen like kind of like a feeding frenzy in like the health tech community about like thinking this is a new market, and like what do you think about that if so?
Yeah, so I have seen actually what I would say a lot of health tech people being the ones who are already in this market are way too overconfident that they can accomplish what is required of them. They're like, we can bill, but they've only kind of the way that they've thought about billing is not one that is going to be able to accomplish all the things that are necessary to be a real Medicaid biller and be responsive to each jurisdiction's need. So I think that it's been a real feeding frenzy on the consultant side of things, where consultants are like super excited to get in there and like dive in. Oh, we've got expertise on this. Where, like eight years ago, if I were trying to talk to these same people about it, they'd be like, no, we're not interested in hearing anything about any of it.
No, really? I'm taking this personally right now.
No, not you at all. Yeah, but I mean, I could name names later. But when it comes to health IT, I think that just people are lost. They're just not even ready for this or even thinking about what it could mean, and it's just above their pay grade. And there hasn't been really great electronic health records even to begin with for these facilities. It's really been kind of an untapped market, I would say.
Yeah. I mean, that's what we hear, and I know you're in it. So one more question, so we can get to Shannon, who appears to be actually on video. So what, most of our audience is like a bunch of health tech nerds. Like, what do you like? Is there an opportunity? How can they help? Like, what do you want to tell these people?
Yeah, well, I would say that we absolutely need tech solutions. We need effective tech solutions, but we also have to make sure that they really need to understand that the correctional space is a very different space. They have their own jail management systems. They have prison management systems. So it's really complicated. It isn't healthcare delivery in just a normal healthcare delivery setting. It's going to really require a lot more sensitivity to also understand some of the needs of this really unique market. So there's a lot of opportunity there, but it's a pretty steep learning curve.
Yeah. Awesome. Well, Dan, thank you for coming on our talk show.
Thanks for having me. Yeah.
In a very wild episode. So we look forward to having you back as the situation progresses with all these things being rolled out in the state. So.
Send us those names.
Yeah. Awesome. Okay. Yeah. All right. Let's see if we can make Shannon show up. She may or may not show up. Oh, hold on. Let me pull you guys back in here.
Am I here?
Yeah. You're here. Welcome to the Health Tech Talk Show.
I have to tell you what the solution was. I quit Microsoft Teams. Of course, it was Microsoft Teams.
Probably always the problem.
I know. I don't actually know that that's true because I quit a shitload of applications.
No, I believe it in my heart. I believe it in my heart that that's true. I blame it. I don't even have
not into it. Yeah, not into it. Well, welcome to the talk show on Vimeo and not Teams. So Shannon, like, I have so many things to ask you right now, but like mostly
we have 9 minutes. You better get to asking.
No, listen, here's the deal. no one knows this, but like it no longer cuts us off at 5:30 because I no longer set an end time. So
Oh,
like
'cause
we
we
can
go
fucking
on.
talk all night. Like we can
Oh,
talk all night.
same.
But like, so here's the thing. Okay, so like Datavant. Well, introduce yourself first, and then I want you to tell us about the personal health record stuff that you guys are doing because I think that's
Yep.
cool and pertinent to the conversation about patients and data and things.
Yes. Yeah, totally. So Shannon West, Chief Product Officer at Datavant, former CTO at the Innovation Center at CMS, led the digital service team there, senior advisor to the CMS administrator. So like all the fun things in government. But at Datavant, we're a health data logistics company that's really focused on leading how we move data in the life sciences sector, in the payer world, and then also for providers. And I'm going to focus in on where we work in the provider world. So I love that people were just talking about a fun thing called accounting of disclosures when it comes to the national networks. Like, guess what, you guys? That's real. In HIPAA, everyone should be able to request an accounting of disclosures. You want to know who manages that? It's managed inside the health system, inside a department that's called Health Information Management. And that is largely staffed by contractors. And one of those contractors who works in that business is Datavant, formerly COCHS. And also, Kat, I just have to tell you, my very kind husband just literally came in here and brought me dinner because I know you and I have talked about this before.
That doesn't happen to me. Everybody's waiting for me. They're like, what are we going to make? What kind of dinner? Like, listen, you guys, every day at 5:40 after the Health Tech Talk Show, I have to go put something in the oven. Like me. Yeah, I'm kidding. I'm happy for you. Leslie, when is your future husband, when is your fiance coming in with your dinner?
I mean, he'd be probably soon, except for he's off on his bachelor party, so he's gone for the weekend. But you know,
okay,
so
all right.
Actually, well, yeah. So
Leslie and I think that we lead a parallel life in this regard. Totally. Yeah, so okay, cool. So back to David. So release of information, health information management. So we are effectively the medical records department for a number of providers in the US. I'm going to say we're about like 30 to 40%. So that means you have a 1 in 3 chance of actually interacting with Datavant when you go to request a medical record. And guess what? Like accounting of disclosures happens. In my team, we've been actually building a platform that integrates using FHIR APIs. No one talks about those anymore because we're busy talking about every other form of data exchange right now. But like integrating using FHIR APIs, they don't always work. Although I will give a shout out to Epic, who's like APIs are the best to integrate with. So we'll give them another set of props this week. But we're in like 300 health systems connected digitally. On the back of that, what we really wanted to do was remove the burden for patients to have to pay for their medical records. So last month, we announced an initiative where we have removed the $6.50 charge that has plagued patients every time they request their medical records. For health systems that are using our technology to bring down the cost to operate the medical records department, it means we can give patients their records for free. Incredibly excited because there's multiple vendors in the ROI space and hoping that we are just setting the baseline for where everyone should be, which is patients should be able to access their medical records full stop, and we should not create burden to do that, including costs, especially for underrepresented communities.
That's pretty freaking cool. So I don't think I realized like how it actually works. So for any of your customers, patients can make a request and get their data for free.
Yeah, there is one caveat, which is every customer who's moving to our to basically our automated way of doing release of information, it's there, it's available. We've made a lot of space to make sure that many customers qualify for that, because really our goal here is to support patients in that process. We released a tool to help patients request their medical records. It's available at individual health systems. You guys, it is like the most simple web form. Every Friday, I get an email with the feedback from the web form, and it is like the most glorious email. It is 100 to 300 people saying, this is the best thing I've ever used in healthcare. And every time I look at it, I'm like, it's a form. And I'm like, that's how bad. Like, that is how shitty we have been. Like, we have made the experience for people to request medical records, to engage with health systems, that like they're stoked on a form. And you know what? I am stoked also on that form, because it means that we can do things like this for patients. We'll stop.
The bar was so low.
Simple is great, though.
Yeah, totally.
Like, you know, like a lot of times I get in fights, and Leslie, I know we've been in these situations together, right? Where we're working with, you know, we have to write, patients are our audience. And that means we're writing on like a 4th to 6th grade level, y'all.
Yeah.
And like, you know, a lot of times our clients are like, there's not enough big words in here. And you're like, listen, dude, or lady, whatever, person. Like it is actually like a certification to be able to write on that level. And so like, I actually think like, to your point, like, yeah, it's simple, but like, that's kind of the point, right? Like you even said, like, we want to make it accessible, underserved community. People don't have a lot of time.
Yeah. Anyone should be able to do it. I had a funny thing happen this week. It was the eclipse, right? I'm not sure if you guys went outside with your little.
I was on an airplane.
Really?
And like, just so you know, my airplane didn't get taken down.
Okay,
like
wait.
Did they force you to close all the windows?
Some of my blood relatives alerted me that they might take my plane down with the eclipse, but it didn't happen. I was flying to DC from Atlanta. It wasn't exciting.
In the path. So on the day of the eclipse, as Kat and Leslie both know, I have horses. This has like been part of my life for a long time. My horseshoer was here, and he goes, the eclipse is coming. And I was like, oh yeah, tell me more about that. Total conspiracy theorist. I love it. Tell me about it all day long. He goes, here, put my welding hat on. So I get to watch the eclipse through a welding helmet. While he tells me, by the way, no risk he's ever going to see this, so I'm okay to tell you a story. Well, he tells me that the world might go dark for 3 days after this. And I had this moment where in the middle of it, I'm also like listening to a work call. And all I could think was like, every time that I'm designing a product that we're thinking about what to build, I have to also include the person who still gets healthcare, who might believe that the world is going to go dark in 3 days, but still needs to make sure that they get their medical records, still needs to make sure they do all these things. So like that, to the simplicity point, like that's it, full stop. Like it doesn't need to be complicated. We don't need to make things worse for anyone who's already struggling to engage with any sort of system. Also, like, God bless my amazing horseshoer who's the best human on earth. But like, he's got to request his medical records.
I love that full circle. I was wondering where that was going.
I mean, that was good.
I really like that full circle.
Actually, very impressed with the narrative weaving here. Yeah, that was like super legit.
So like, you kind of said this was something that they were asking for. Like, it was so bad that your patients were asking, like these patients were asking for something like this, or is this like a proactive
medical record?
Yeah, I know.
It's terrible, right? Like you have to fax in a form. I sent one into like an old health system in Arizona the other day, not one of ours. So I can talk a little shit on it, but like I sent it in. 2 weeks later, I got 3 letters in the mail that asked me to fill out the same form again, but written.
Yeah.
And the week before that, right? Like I had just gone to Emory and had requested my medical record using our form, was able to get an email with my medical record in it. And like, it was just some lab results that I wanted fast. And so what we've heard consistently is like, we need to make the process easier. It's incredibly difficult. By the way, you guys working in PR marketing, it brings down like Google stars if you don't have that good patient experience. Whereas our tool for folks in health systems listening gives the option for patients who are using it to then go and actually give 5 Google stars to the hospital or the health system and say like, this was the best experience that I've had. So there's a lot there.
I talk to companies all the time because this is one of those things where people just assume that's already the case. Like, how like we all know that healthcare is consistently 10, 15 years behind, depending on who we're talking about. Like, this is one of those things where it's like, it should not be this complicated. And if they walk in, even if they have the best experience with these health systems in every other regard, and they try to go do this, and it's not just a simple online form, it's not really that exciting or impressive, and not in some fancy app or whatever. It's like people aren't craving that anymore. They just want like what they expect.
Because not everyone, right? Like not everyone wants the app. I don't know. I always tell people like I want to keep my records in like
people
a Google
hate
Drive.
Apps now.
I don't want them in some shitty app. Like I don't want that. And there are people that do. And I think the reality of the health system is we have to be able to just meet people where they are and do that consistently. Yeah. And that means different offerings across different people for sure.
Totes. Awesome. Agreed. So wait, so Shannon, can we talk about like individual access and like, all this stuff, just like broadly, right? Because I know that's not, you can submit such a request on the national networks, but there's no requirement that it's returned, that anyone responds to it. And the same under TEFCA right now. I know that's like a plan to like make that something that has to happen, but like this is like one of the only ways where you're like guaranteed a return, right? Assuming you have something like Datavant at a hospital at your customer where a patient can, fill out this easy form. Like there's like just not a lot of options.
Not only are there not a lot of options, but like, I think one of the recommendations that I've seen from Brendan and other people in the situation that's going on is that patients should be able to have advocacy over where their records are shared. And it's interesting because I wonder if is Mickey Tripathi listening here?
No, I don't know. I don't know. By the way, loyal fans, Mickey Tripathi is booked for our May 29th show, or 26th, whatever. It's the last Friday in May. He's showing up. So we'll see what happens.
But, it's interesting. I posted this somewhere on LinkedIn. Josh Mandel and I had this conversation about what happens when there is like a questionable request for a patient's medical records. And the answer today, right, is if a questionable request comes to, say, like our people in the health systems, they're going to look at it and they're going to call the patient, or they're going to send the patient a letter and say, so-and-so. Actually, it happens to us when we're requesting medical records. Like we'll get a letter back, or we'll hear that basically a patient said, I don't know who they are, because we're requesting medical records on behalf of someone who's requesting medical records on behalf of them. Yeah. But the reality is, like, there's that moment in time where that can happen. And in the national networks, in Kafka's design today, like we haven't given that moment in time for a patient to be able to be engaged and involved and be able to say, like, wait, that I didn't authorize that. And there's a bunch of reasons why, like, we shouldn't put patients at the center of every single transaction. Ryan Howes is probably listening and like raising his fist at me a little, but like there are exchanges that happen that we should allow to happen without the patient needing to like authorize it. As per HIPAA, it is allowable. But what we should do is make sure that there is the ability to audit. And also that in some transactions, including where it looks like an individual access request, that the patient is informed and can know. We often see, like, there might be an attorney who actually in our form, you guys will appreciate this, in our patient request form, there's a portion of it that requests basically like a photo ID, and you'll get the form with the patient's information, and at the bottom it will be someone else's ID, and you're like, WTF? And the team might go Google it, and it's like an attorney who's trying to request records saying that they're the patient. It's like very, very weird, right?
Wow.
Yeah.
Fascinating.
Wow. Yeah. Wow, that's wild. And I guess they just assume no one's going to check. They're like, oh, check in the box. I put my ID there.
I think so. I mean, right? Like just always trying to figure out a way to get around to get the records. And like healthcare is gamed every step of the way. I think we need to put protections in place. And we just need to acknowledge it.
Totally
That's
is.
real. Yeah.
It totally is. I was talking to a doctor. Oh, sorry, Leslie, go ahead.
No, go ahead. Okay.
So I was talking to a doctor today about this, and he was like, yeah, like it's so hard for me to get data at the clinical level. Like I always figured the more data, the better. And like you're saying, like, whoa, like there's some scary stuff out there. And I was like, yeah, like I totally get what you're thinking here. But like it is scary that some of this stuff just gets flung around, and like abuse is real. Like I think there's been a lot of chatter about that. Like the abuse on the national networks has been like a thing forever. As long as they've been around, but. People do game it, and it's like not the best.
I mean, it's true, and like it's always been true in medical records and clinical data access, right? Like it's why we need protections in place, and I think that there is a question about how in spaces where that trust is like abdicated to a group or is put in kind of like a couple steps removed from the provider or from the patient. Like how do we make sure that trust can proliferate and continue? Because I think the narrative that I haven't seen happening, because everyone's really focused in the acute moment, is over time, are we getting to a place where people trust data exchange in healthcare less and less? And do we actually swing back around to a place where privacy restrictions could be so strong that actually the move of clinical data that you need to happen in order to support the administrative side of healthcare ends or becomes so complex that actually it does mean people get denied care, or you don't get access to information that you need, or your requesting physician doesn't get it. And it's the thing that keeps me up at night is like, how do we continue to maintain a world where we do right and do good for patients and every other actor in the health system so that we can continue to exchange data? Because there's a world where we could swing the pendulum hard the other way.
Right.
Yeah.
I cut you off. So it's your turn.
No. I'm sorry. I'm thinking about what you said about the guy with the ID at the bottom, but everything you just said too. It's like also, the not an idiom, whatever it is, the theory of like, you don't fix problems until you know there's a problem. It's like we all theoretically know that this is gamed, right? But how do we actually get someone to do anything, or how do we monitor it? And you can't really monitor it when it's that layered, so who's responsible for monitoring it? Should you guys be tracking how often somebody's trying to access information that's not them? You know what I'm saying? Like that type of stuff. Who owns that responsibility of proving how big of a deal this is? That's what I was thinking about.
I mean, it's super interesting. We like Datavant isn't walking around like making up rules for how data should be exchanged, right? Like Datavant acts on behalf of the providers that we work for, and they might have like rule books, etc., that we are basically just implementing. And I think that like that's the really interesting thing about this world still existing, like this world of human beings who are like sometimes printing and mailing medical records, is there are people who are making judgment calls. And I think often about a world where when we start to like obfuscate more and more of that away, where does the decision making go, and where do the individual policies move to in terms of enforcement? And today when we build all these FHIR integrations, we largely support exchange for insurance companies, so for Medicare risk adjustment and payers. So we're effectively building like the non-treatment use case network in a bunch of ways for our customers. And the interesting thing that happens is we are effectively the arbiter between a provider and a payer, because the payer says, I want X data, and the provider says, that's great, but you can't release student notes, you can't release X, you can't release Y. And do you know what I do? I filter all those things out because it matters to the provider, and because there is not an explicit definition of what data should be included. And so someone is having to interpret what minimum necessary and HIPAA means. And we are the trusted partner and providers to do it. We're now just translating it to technology. So
speaking of trust, like I love everything you're saying. Like, what's the right thing to do? Like, assuming there's been some deterioration in trust in data exchange right now, and I think we'll see what happens there. What's the solution? Like, how do we make sure that pendulum doesn't swing all the way to the bad way?
I mean, I think that's a great question. I don't actually know that I have a good answer right now, because I feel like I'm just I'm like an outside viewer in the current situation. But I think the really critical part is like there needs to be transparency in decision making, and like a clear understanding of the things that are happening, how decisions are being made, what the processes are. And I think also translation of that to like real time, what's happening post like an inflammatory incident that's happening on the internet. And like, what is the day-to-day like? I think one thing I've always wondered with the national networks is like, can we see who participates? I think that this was also a recommendation in Brendan's article. And I've always wondered, like, can you see who participates? Can you see who has some sort of infraction against them? Like, there's lots of, lists like that inside CMS. Should the same thing also be true in those contexts? But I also think we do need to allow some continued preservation of providers and the entities that are really engendered to implement HIPAA and the requirements of HIPAA to be able to do so. And so, I think there's a lot there, and I'm not convinced that we get to a place where the entire health system agrees on how to exchange data for every single use case. And I think it's why I work at Datavant, because I believe having an arbiter that can do that in a technical way that can allow data to move fast is critical to us being able to move forward as a health system.
Yeah, I agree that, especially, we have, and, we've heard about this from a number of the HIEs in very red states, right, where abortion is now like fully illegal. How do you, whose responsibility is it to disclose the right information? And, that's in many cases, like, the providers feel like that's their responsibility. So it is funny, like what you're saying. I think a lot of times in this discussion about like broader national data exchange, like we kind of forget about the providers.
we like, absolutely. It's like they just like go away. But I would argue, I think we also forget about patients. Like I always see that. What's the number that's like 700? No, exactly. It's like 700 million transactions. And I'm like, no, like that's 700 million patient lives whose like private health information is moving through your networks. And do we remember that those stories tell like intimate details of someone's life? I never see like medical records anymore. I'm pretty abstracted away from it, but we had an issue recently with the formatting, and I'd asked to see how something was being rendered, and I was looking at a medical record, and it like hit me. I was like, oh shit, like I'm that person too, where I've almost like abstracted away that piece. And so now I keep reminding myself, like every single one of these represents a human being with like a critical health thing happening that we need to be really, really careful of.
Yeah. No, abso-freaking-lutely. And then I'm just also, Leslie, you say one more thing, but like so transparency, like that's actually my answer to this is like, hey, if you've lost trust, like really the only way to rebuild that is like straight up transparency. So like how, even for vendors involved, right? Like how can you be very transparent about what you're doing? And I know the national networks are like private entities, right? So like it's hard to say you need to be transparent. They're not, like TEFCA, I think there could be something there where it's required, and maybe they have the naughty list like HHS has for data breaches or something. But that's really the only way I see that like we're going to build trust and move forward.
Yeah. Which I think we have to, otherwise we're going to either be in a place where like patients have to click a button to share their medical record every time. And like back to my horseshoer who's like not going to do that. Like
he doesn't push buttons.
Back around. Yeah, totally.
Oh my God. All right, Leslie, any final questions, or Shannon, any last words? Because like I said, you guys, I got to go make dinner. Like I'm not living in the same world as you guys.
Nah, I had a great tax story. I was gonna like it, but I'll save it for the next one. So it'll be totally fine.
Shannon, Leslie guest host again, middle of May. So yeah.
Can't wait to see you in a couple weeks. Thank you guys for having me.
Oh, that was delayed, but great. Yeah, amazing. Any final words, Shannon, or we're gonna like cut this shit off because we gotta go.
I think in all caps in the chat it says, "I don't know. I hate technology." I'm just gonna.
Yes, it does.
We'll just reiterate that here as audio cuts out. Thank you guys for a great show.
Oh my gosh. Well, thank you, Shannon. Oh, Leslie, this is the wrong thing of you. Thank you, Dan. Thank you, Melissa. Thank you, Lisa, for joining us from the United Club. We hope your plane does not fall out of the sky. And you guys are the best. And thanks for like kind of a fun and ridiculous show as usual. So goodbye. I have to go make dinner. I don't even know what I'm going to make. So